Okay, good morning, everybody, and thank you for taking time out of your busy day to listen to me talk. This is a talk that some of you guys have already heard. It's just my general kind of overview of how I think about the disease of addiction and addiction treatment. I have several versions of this talk. Some of it, one of them is just for the general public. One of them is for other physicians. This one's kind of a melding of both of those. Most of us, for a lot of us, this will be a review. For some of us, it might be new information, but we'll get through it anyway. I think it's important for, particularly in the disease and diseases that we treat in terms of co-occurring things, it's important that we're all on the same page and that we're speaking the same language to each other and to the patients, and then we're all taking the same approach, because a unified front to addiction treatment and recovery is important. So I won't belabor the introductions. You guys know me, you know where I work and what I do. And there we go. Okay, so these are the points that I'll try to make in the talk. I'll start with just talking about the history of our approach to addiction treatment and the evolution of that over time. Give you my understanding of the biology of addiction, the neurobiological underpinnings, the genetics per, what I've gathered by studies and per the American Society of Addiction Medicine, a definition of addiction. And then I'll talk a little bit about treatment in the context of that model, and then close with some reasons, or the reasons why I think that's important, and why I think it's useful to patients to use that model versus a different approach. So, for a long time, like other things that we don't understand in our society, we stigmatized drug use and addiction. If we don't know the science behind a problem or better ways to treat it, we use morals, to say, this is evil, this is bad. And it's same way with, pork and oysters before we had refrigeration. We didn't realize that bacteria causes these illnesses. And if you leave the meat outside the refrigerator, whatever, for too long, if it sits out, the bacteria grow and you get sick. So rather than come up with other ways to address that problem we didn't understand, we just said, pork is evil, don't eat it, and that stigma still, unfortunately, is around and pervades society some, because it hasn't been that long that we've been trying to think about addiction in terms of biology and brain disease. Kind of the next step in the progression of our understanding of the biology of addiction and disease of addiction is that's also still, unfortunately, pretty prevalent in the treatment world as well. These patients must be self-medicating some other condition. So, maybe they have depression and they're using alcohol to help with their depression, or they have an anxiety disorder and they're using the opioid to help with their anxiety disorder, or whatever. And that's a step towards, treating addiction as a disease, but it's an earlier step, and not that much further down the continuum from that is kind of how the DSM lays things out. Well, our patients are probably just normal people who use so much of a drug that now their brain is different, so they've caused the disease by drug use. And if you look at the DSM, so the DSM, that for those of you that don't know, all of you probably do know, but that's the manual that we look to for our diagnostic labels that we use to treat people. And in that book, what's that? Okay, there are different, it's broken up into different dependencies, right? So you have alcohol dependence, or these days it's alcohol use disorder, and opioid use disorder, and cocaine use disorder, nicotine use disorder. So, which implies, if you really look at it, that the drugs kind of caused the problem, because it's all related to a particular drug. And And also under that model, if there are any other symptoms that you see in that patient, like mood symptoms or cognitive symptoms, we would use another label to describe those, like major depressive disorder, generalized anxiety disorder, bipolar disorder, sometimes ADHD. So you end up with, 10 different labels to describe probably one unified neurobiological condition. And so,
Caudill, can you let Morris in real quick? He's in the waiting room.
Let's see, how do I do that?
Down by probably participants. If you click on that.
Okay, here we go. Very good. Okay. And so the next stage, and what I think is the evolution of the understanding of addiction and treatment of addiction, is kind of what we all see intuitively anyway, right? In our patients that carry a diagnosis of alcohol use disorder, we all kind of know that, well, they're probably going to have problems with other drugs too. So it's probably just not about the alcohol. They probably shouldn't take pain pills, and they probably shouldn't smoke marijuana either, or lots of them are going to smoke. So these people tend to have problems with lots of things that we call a drug, and also lots of behaviors. And we'll talk a little bit about what those drugs and behaviors have in common in a few moments. But what we see in our patients is almost always more than compulsive use of one drug. And it's also almost always some other symptoms other than drug use, mood symptoms, cognitive symptoms, focus symptoms. So what we're really looking at, and what the American Society of Addiction Medicine tries to capture with their newest definition, is that these people have different brains, and what is the neurobiology of that brain difference, right? And that the drug use and other behavioral problems, compulsive behavior, gambling, shopping, sex, things like that, are all symptoms of that underlying brain disorder. And so that implies that these people had different brains before they ever used drugs, and that will also have different brains after they stop using drugs, which is what we see in the natural history of the disease, and what we see, in recovery, right? We all know that people don't just go back to normal when they stop using the drugs, and that that you kind of have to be in recovery for the rest of your life to stay in recovery. And we've come to realize that over time that there is some school of thought that kind of tries to cling to the old way of looking at things and say, well, that's just because these people have ruined their brains to the point of no return and they can't be fixed. And that's why we see that chronicity. But I believe, and I think there's good science that says, well, they were probably like that beforehand. And so rather than using the language of, alcohol dependence or nicotine dependence or opioid dependence, which we still have to do to get paid and for some other reasons, I will use the language, well, addiction with compulsive use of blank. So addiction with compulsive use of alcohol and opioids and nicotine, right? Or just to try and capture that this is one person with one brain with one problem that has lots of symptoms, rather than 10 problems. So this is the definition of disease from the Oxford English Dictionary that says a disorder of structure or function in a human, animal, or plant, especially one that produces specific symptoms or that affects a specific location and is not simply a direct result of physical injury. And we'll go into each of those criteria and show why this model best captures that definition and why addiction is exactly this. It has specific symptoms, it affects a specific location, and this is the important part, it's not simply a direct result of physical injury, meaning it's not caused by use, it's primary and pre-existing. So this is, we confuse withdrawal and addiction, right? Which is easy to do, for our patients and for us. So withdrawal is what happens when a normal person or one of our patients, when anybody uses enough of certain substances, animal or human, in experiments or whatever, when they stop, they're going to have certain symptoms. we're familiar with alcohol withdrawal. People have, the shakes, seizures, delirium, mood problems, upset stomach, headache, opioid withdrawal with just the terrible dysphoria and chills, runny nose, fever, body aches. We're all familiar with those withdrawal syndromes. Amphetamines, cannabis, well, a lot of drugs have withdrawal syndromes, but these are the two that are most prominent that we know the best. This is not addiction. This is withdrawal. It's usually related to increased norepinephrine tone in a part of the brain called the locus coeruleus, where addiction is a different imbalance in a different part of the brain that we'll talk about in a bit. And again, I think that the way that the DSM breaks it up into separate conditions that kind of implies that drugs cause the problem plays into this confusion between withdrawal and addiction. Withdrawal is what happens in the first week or two or so when they're in treatment, is usually time limited and goes away on its own. We treat that. Addiction is the thing that leads them back to using once the withdrawal's gone, and the thing that needs to be addressed long-term for them to stay in recovery. And it's the thing that was probably there before they ever used the drug to some degree. Now, the drug use makes it worse, but there is the underlying neurobiology that has always been there and always will that we treat. So this is the normal, this is location from that Oxford English Dictionary definition of disease. This is a cartoon of the brain. These are the parts of the brain, or the main parts of the brain of where addiction kind of lives. The nucleus accumbens, the arcuate nucleus, ventral tegmental area. There's some other associated regions, the amygdala, where memories and cue-induced craving associations occur. The prefrontal cortex is affected by what happens in this part of the brain in terms of people's decision making, and we will talk a little bit more about how our patients are different in this part of the brain compared to the general population. So the nucleus accumbens, this is the part of the brain that is responsible for us meeting our basic needs. It is where our instincts live. It is what drives us to do the things we need to do to live, like eat and reproduce and work so that we have shelter and be a part of a social network. All of these kind of things that we don't think about much that just kind of happen automatically. This part of the brain, the way that a good way to understand it is to think about hunger and food. And we've all heard the term hangry, where when I haven't eaten enough food, my blood sugar drops and my brain makes me very uncomfortable and irritable and restless, so that I will not sit there and starve. That emotional discomfort motivates me to get up and go get food. And then when I get the food is pleasurable. So there's a little release of dopamine in my nucleus accumbens. And I get that pleasure from eating, and then I'm more comfortable, I'm relaxed and content after I eat. All of that happens in the VTA, the nucleus accumbens, in the midbrain, and that's where addiction lives. We'll talk about this in just a moment, but it doesn't do that as well in some people as it does for others, right? And so this part of the brain makes you irritable, restless, and discontent when your needs aren't met, and makes you content when your needs are met. It also has the ability, like I was saying earlier, these parts of the brain have projections to the prefrontal cortex, which is where higher reason exists. It's not that's an oversimplification, but it's the part of the brain where we balance our values. We weigh the pros and cons of decisions based on our true values, and we make decisions. Well, if my midbrain is telling me that my needs aren't met, it influences my decisions so that I will get my needs met, right? An example is, right now, if I'm hungry, I'm probably not going to go a few offices down and take Grant's lunch because I know I can wait till I get home if I left my lunch at home. And that's my prefrontal cortex saying, no, your beliefs are you shouldn't take from other people, and you can be patient and all of that. And so my behavior is influenced by that in a good way. if there were no food in 30 days from now, if I'm starving to death, my midbrain will tell my prefrontal cortex, I don't care what you think, you're going to go steal that food or you're going to die. And that gets hijacked in addiction in a way that explains kind of what looks like very irrational in behavior in our patients that doesn't make any sense, most notably them continuing to use despite all the consequences. But just to say that the midbrain has the ability to take the prefrontal cortex offline and affect the way we make decisions. We tend to think of our human psychic life as different than that. We kind of, it seems as though we think our way through life and we make these rational decisions and then we act on them. But our instincts and the drive for pleasure and reward and satisfaction have a lot more to do with, it's actually the other way around. Those kind of more animal instincts influence the way we think, often more than the way we think can influence those instincts, right? Like try not to eat, and because you know, it's not the way we think about it, and our midbrain's a lot more powerful than we think. And you see that in our patients. Okay, this is the definition of addiction from the American Society of Addiction Medicine website. It says addiction is a primary chronic disease of brain reward. So primary chronic meaning been there the whole time, will be there the whole time, not caused by any other disease, not caused by depression or bipolar disorder or some other thing. It's a disease of brain reward, motivation, memory, and related circuitry, like we just talked about. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations, all of which we try to address in treatment here. And this is reflected in the individual pursuing reward and or relief by substance use and other behaviors. So this is a graphic that I use to try and explain this concept of dopamine tone. So we talked about the midbrain and the reward centers and how that functions in human behavior. The predominant neurotransmitter of that system is dopamine. And all of us, so there's this, we call this a bell curve, and all of us, our natural overall activity of that system, which I use the words dopamine tone to describe, I was taught that. This kind of refers to the overall baseline activity of that neurotransmitter system. So it's not just dopamine levels, but it's tone, which, you know, there are 10 different receptors and production of dopamine and release of dopamine and what happens to dopamine after it's released. So there's a lot of variables that go into this construct, but all of us lie somewhere on a spectrum with respect to that construct, right? So if normally, and this is just showing that, I don't need to get into this too much, but if my baseline dopamine tone is down here, and then I use something that spikes dopamine, well, that makes me feel better because it moves me from here to up here. Can y'all see my cursor there? Oh,
Yeah, we can see it.
Okay, good.
Yeah.
So if my baseline dopamine tone is there and I use a drug or a behavior that spikes my dopamine levels, I go from here to there. If my dopamine tone is more normal, always up here, and I use a drug, then that doesn't really make me feel better, because if you get over this curve, you start feeling bad. And too far over this curve, you start getting, you know, psychotic symptoms and hearing things and seeing things. That's what happens when people use too much meth and cocaine. So that's just to illustrate that our patients probably live down here in the range of low dopamine tone, so that when they use a drug, they go from here to there, and that has a profound effect on them. And also the next slide kind of illustrates that too, right? So this is what happens in the nucleus accumbens when you use a drug or any of these rewarding behaviors, you know, gambling, sex, sugar, food, and each drug is going to do this better for different individuals based on what that individual's particular genetic background is, and we'll talk about that and what their genetic code is. But when you use a drug, dopamine levels spike and crash, right? And if you normally your dopamine tone is up here, you don't get a big spike and crash. But if your dopamine tone is down here and you use a drug, you get a big spike and crash in dopamine. And the brain interprets that big spike and crash in dopamine as meaning that you're that this is important for survival. But it only happens really in people that, most of the time only happens in people that have a low baseline dopamine tone, because that allows that big dramatic relative change, right? That's the same thing that happens in a normal person that hasn't eaten in a month, like I was describing earlier with Grant's lunch, right? If I hadn't eaten in a month and I went and I ate Grant's food, I would get this big spike and crash in dopamine levels, and my brain would tell me, you need to keep doing that to survive, so it would be easier for me to do it again. Drug use in our patients, in our patient population, mimics that situation, so they wouldn't logically think that drugs are needed for them to survive, but their midbrain believes that, and it influences their judgment and their decisions based on that big relative spike and crash they get, which is based on where their brain was before they ever used a drug, and therefore the drugs could have a different effect than they would on normal people. This is a, some of y'all will recognize this, Melaine especially probably. I hijacked this from the place we used to work and covered up their names, but this is a cartoon of the parts of the brain that we're talking about. And this just shows a couple things. These are all the different proteins in the brain, or models of those, that add up to dopamine tone. These are the variables. So these are dopamine receptors and cannabinoid receptors and glutamate receptors and opioid receptors and nicotinic receptors and GABA receptors. And if you have a combination of genes for these different little parts of your brain that do the job of providing normal dopamine release and reward when that should happen, when your instincts are getting met, if you inherit the genes for little proteins that don't work as well as others, enough of that, you end up with this low dopamine tone that is the pre-existing disease of addiction. So I wanted to just say that with this cartoon, and then also just show you that this is also where all other drugs, this is where drugs of abuse work, right? So opioids bind here and cause dopamine release in the nucleus accumbens. Benzos bind here and cause dopamine release in the nucleus accumbens. Cannabis binds here, or THC binds here and causes dopamine release in the nucleus accumbens. So if you've got a certain configuration of these genes for these proteins, you have low dopamine tone. And then when these drugs come and tell the brain to release dopamine, you get a more dramatic spike and crash in your dopamine levels. And that's what we're seeing in our patients. Now, not every single one of our patients has low dopamine tone. When you repeatedly, but probably 90% of them, I would say. But it is possible to just use enough of a drug that your dopamine tone lowers. But that is the exception to the rule rather than the rule in my experience. But that's also important to say that there's the baseline low dopamine tone, but then drug use repeated over time further lowers dopamine tone. So the first thing you have to do, and that's because every time you release dopamine here, so our patients are pushing these buttons way too frequently, and so they are depleting what dopamine is there, which is low to begin with, and so the using worsens dopamine tone. So the first thing we have to do is help them stop using, and then let their brain heal a little bit. Then they get back to like their normal baseline dopamine tone, which is low. And then we have to help them work on that. And everything that's ever been shown to help anybody, feel comfortable in their own skin in recovery and not use, does that by improving midbrain dopamine tone or stabilizing. And we'll talk more about that in a bit. So this is just a little cartoon I made. I'm impressed with my artistic abilities on, this is terrible, but I think it gets the point across. So it's kind of an artificial distinction, right? So in medicine, we have these constructs about disease, right? Blood pressure is a good example. Everybody has blood pressure in our society. We arbitrarily say, well, probably the worst 30% of average blood pressure, we're going to call that hypertension because we think that leads to problems down the road. And we think it's worth treating those people that have the highest 30% of blood pressure. So we're going to kind of arbitrarily draw the line right there. But, there are people that might have blood pressure that's in the down here or down here, and do you treat it down here? Well, sometimes maybe, I don't know. So, and it's the same with addiction, right? We kind of call the worst 15% of dopamine tone, I think, about that. If you look at the general population, that's about the percentage of people that end up meeting criteria for a use disorder, according to the DSM, at some point in their life. So we kind of arbitrarily draw the line for the disease state as below, the 15th percentile, but occasionally we'll see patients that are 18th percentile and 19th percentile, right? Like, my wife comes from a family with a lot of alcoholics, and she's not an addict, but she's had a few times when she's overdrank and stuff like that, and I can kind of see some of that genetic load in her, but probably not enough to where she's ever going to need treatment. So maybe she's up here. So it's not black and white, is what I'm saying. And everything, we use these models in biology, and because it's the best we can do when they're useful, but we're still applying, human thought on what we see in nature, which is very complex. So low dopamine tone, said that a lot, but if there is low dopamine tone, then there's pre-existing disease, and there are symptoms other than drug use. So that spike and crash that tricks the brain into thinking that drugs are important for survival happens in our patients because of their low dopamine tone. But there are other symptoms that happen when someone has low dopamine tone that were probably pre-existing to a large degree. And you can think about those symptoms as being like the patients are always hangry, right? Even though their needs are met, their midbrain is sending, acting as if, and activating the emotional centers and influencing the thinking as if their needs aren't met, so they'll go get their needs met. So our patients are irritable and restless and discontent, right? That comes across in words like depression and anxiety, and sometimes it's very similar to bipolar disorder too. There's affective instability and impulsivity and irritability. But if you really take a good history, it's different than, say, like bipolar disorder, but it looks very much like I tell my patients: depression, anxiety, some bipolar 2 type symptoms, plus compulsive substance use or compulsive behaviors that spike and crash dopamine, plus concentration and focus like ADHD symptoms. All of those things are what you see in somebody with low dopamine tone. And if they never used a drug, then you probably would see the depression, anxiety, bipolar 2 type stuff, and the ADHD type stuff, because those, I think, are just related to low dopamine tone that aren't necessarily caused by the drug use. Drug use is caused by that low dopamine tone, and drug use makes all the symptoms worse over time, if that makes sense. The ADHD stuff, if you think about, if our midbrain believes that our needs aren't met, just like when we're hangry, it gets our thinking mind overactive because it's trying to solve some problem that's not there. So our patients overthink things, so they seem distracted and easily distracted, and they have what seem like short-term memory problems because when they lay their keys down, they're not paying attention because they're thinking, and that's just because their brain is kind of in hangry mode when their needs are met, and so that explains, what the ADHD type stuff that we see. Okay, and also you can usually see some kind of behavioral stuff before they use drugs too, like being a teacher's pet, or people pleasing, or attachment problems, behavior problems. What we think of as like axis 2 stuff in psychiatry, a lot of that is rewarding and activates these parts of the brain. So people that have low dopamine tone are more prone to those things, and you can see those in the history before they ever use a drug. Just more, evidence that these people have always been different. Yes. So, and the reason, it's like any other disease, it's nature and nurture, right? Nature refers to the genetics. Nurture refers to, environmental stuff, experiences in life. And so it's not all genetics, but I don't know how the geneticists come up with this, but what I was taught was probably 60% genetic, 40% environmental. And there've been lots of studies that look at, twins that were adopted out at birth and raised in completely different environments that didn't know each other, and the concordance of addiction in those two individuals is really high. Another statistic, people, if you have addiction, the chances of your offspring having addiction are 8 times more likely than if not. And there's just a lot. There's a lot of evidence that it's a genetic disease, and we're learning more and more about the specific genes that are that result in that concordance that we see. And these are some of those genes. This is an actual printout from a patient. Our patients can have this done today, where there are companies that can run their DNA. They can upload their DNA from 23andMe, and that company can tell them what genes they have that put them at risk for addiction. I've worked in places where we did it for every patient, but because but insurance doesn't pay for it in our patient population, it wouldn't be cost practical. And most of the stuff I can get from the history anyway, but this is helpful stuff to have when you're treating them. But I just show this as an example. This is from a real patient. I've blocked out their particular genetic code just so that, because it's kind of a patient identifier, but this is the gene that helps the brain make dopamine. So this is the deplan gene. And if you have a problem in this, then you would respond to L-methylfolic acid supplements. And that's why we prescribe so many of those, because the prevalence of this in our patient population is about 90%. And remember, for those of you that don't know, you probably all know, but they were born with these genes. So these are particular sequences of DNA, and DNA is the instruction template for proteins to be made. And proteins are the things in our body that do the work that our body needs done, like those little proteins in the cartoons that I showed you, the brain model, the opioid receptors and nicotine receptors. Patients are born like that. And if they're born like that, they've always been that way and they always will be. Now, this can be modified some through epigenetics and some other things, but essentially this is the nature part of the nature and nurture. But so this is a serotonin receptor that if it's too sensitive, then that can cause decreased dopamine release. This is an opioid receptor that doesn't work as well in some people, that contributes to decreased dopamine release in response to normal reward. This is nicotinic receptor, the same thing. Just to show you that our patients are wired this way, and the research on this is early, and we need more, but it's exciting because if we could identify more of this stuff, well then, a lot of people make the argument, well, if my patient has a problem with their nicotinic receptor that's contributing to their underlying brain disease of addiction, the low dopamine tone, maybe they'll respond better to a medication that activates this receptor compared to somebody who doesn't have that particular bad gene, for lack of a better description. And this is where, for example, Chantix works, is on this receptor. So you can kind of tailor patients' medication regimen to their particular neurobiological differences and needs. This is just another, so this is a cartoon similar to the one before. Let me see. That just shows, these are those, the result of those genes that I showed you. So the genes are in the DNA, and those are the instructions for the body to make these different parts, that if these parts don't work like normal people's, they add up to low dopamine tone. So a little bit about trauma and neglect. That's probably the most, PTSD would be the most common kind of genuine co-occurring diagnosis that I see in these people. A lot of them will meet criteria for a lot of things, but in terms of like separate processes that impact the brain disease that we're treating, and things that absolutely have to be addressed in treatment, trauma is probably number one. Y'all all know that. You ask, I don't know what percentage of our patients will endorse a trauma history, but it's at least half. And what trauma doesn't cause addiction, in my understanding of the biology. Some people believe that it does, but I don't think so. But I think trauma is the biggest part of the nurture part of the nature versus nurture dynamic. And trauma lowers midbrain dopamine tone. So it worsens that underlying neurobiological difference that is the disease. And that's been demonstrated in these poor animal studies where they'll take baby monkeys from their mother too early, and those baby monkeys will be more prone to use drugs. And then they put the baby monkey back with their mother, and the baby monkey stops doing that. That's a little different than what you see in our patients, because those monkeys probably aren't low dopamine tone to begin with. Or there have been lots of rat studies where they'll look at if rats in a bad environment or traumatic experiences in rats will make them use more drugs and so on and so forth. But and it's important to treat that, of course, in our patients, and you know, the really therapy, the stuff that you guys do is probably the mainstay of that. Medications aren't so helpful for PTSD. There's a few we can use, but anyway. And then, of course, there are other co-occurring disorders. Bipolar disorder is a separate thing that we see in a small percentage of our patients. It's probably overdiagnosed, but it's certainly there. That's probably the biggest one. Chronic psychotic disorders happen and have to be addressed. This is just a quote from one of my people that I look up to and kind of a personal idol of mine in terms of my career and history. But this is from a letter from Bill W., who was thought of as one of the founders of AA, to Carl Jung, who was a psychiatrist who was very good at incorporating spirituality into his science of medicine. But Bill says to Jung, because of your conviction that man is something more than intellect, emotion, and $2 worth of chemicals, you have especially endeared yourself to us. And I put that in there to say I've talked a lot about chemicals and people and behavior, and just to reinforce that that's a model, and people are more than chemicals. But that's in biology in the West and in medicine, that's what we deal with. And so that's why biology is so important to me in this setting. And along those lines, the treatment that we give and that any good addiction treatment center gives is much more than medication, right? We require patients to get involved in outside recovery, AA, NA, refuge recovery, smart recovery, things like that. And what those organizations do, interestingly, is they teach people actions to take that raise midbrain dopamine tone. From a biological standpoint, it's like rehabilitation for the brain, and you can see that on fMRI scans. If you look at people at baseline and then after they've been meditating for 6 months, well, what meditation does is it raises midbrain dopamine tone through increasing the number of dopamine receptors and such, and different things like that. But I tell patients that outside recovery is not just about the meetings, it's about the things they do in the meetings. And those things that they do in the meetings are like exercise. Like if I was your cardiologist and you had a heart attack, I would prescribe some medications to help, which is what we do. And then I would give you some exercises to do that. And doing those exercises, you use your heart. And when you use your heart gets stronger and better at doing what we needed to do, pump blood to the rest of your body. And your brain is the same way. When you use your brain to do certain things, it gets better at allowing you to feel at peace and not kind of angry all the time. And it gets better at allowing you to make the right decisions about using. So it's just like any other organ. And so what they do, the steps and the other things they do, meditation is like those rehabilitative exercises for the brain. Now, there are certainly spiritual ways to look at that, and it goes beyond the biological description, but the biological description is what I just shared. And then all of the, evidence-based psychotherapeutic interventions for addiction, all of these have been shown to improve outcomes in addiction treatment. And we incorporate as much of each of these as we can. And that's where you guys, your end of the team is perhaps more important than mine in the long run. But and then some other things other than medications that help. So just to wrap things up, just kind of in terms of treatment philosophy, why is this important to me? Well, you know, what difference does it make if you call it depression or ADHD or anxiety or whatever? Well, I think patients and families need to know that. I think if you know the problem, you know the solution. And if you believe that the problem is all depression, for example, then we won't really get the good outcome we need, because you can treat depression. You know, you do not stop addiction by treating depression. Unfortunately, we tried that according to that old self-medication model. It doesn't work very well. But what does work well is if you treat it all, and if you know that this is addiction and drugs are a part of the problem rather than a solution, then you'll do all the things that other people do that we do know help and work. It also helps alleviate the stigma. You know, people are full of guilt and shame when they come in the door, and if they realize that they're sick and there's a specific brain disease that's responsible for the way that they've been behaving largely and feeling, then they feel a lot less guilt and shame. And it's also, you know, 12-step recovery is probably the most available and most studied evidence-based kind of community recovery intervention. And this disease model is compatible with what they're going to hear in that organization. And so I think it helps facilitate assimilation into a recovery program in the community. You know, just specifically in terms of the medications, and I'll show a slide that illustrates this in just a minute. Most of the medications that are used for, say, generalized anxiety disorder, major depressive disorder, things like that, don't really help much with midbrain dopamine tone, and so therefore don't improve outcomes very much, according to the evidence that we have. And then just lastly, a lot of times we have to help patients make very difficult changes when it comes to their medication. And my explanation for the reasons that I'm doing that is because it takes an understanding of the biology of the problem and how this medication is going to make that worse. And if the patient can understand that, it helps them to agree to make those changes, which are very difficult. And I'm talking about like someone who's been diagnosed with ADHD stopping a stimulant that they need to stop when they come, or someone who's been given Xanax for panic disorder, stopping the Xanax, right? If they see the use of those chemicals as a compulsive use of those chemicals as a part of their underlying brain disease, and it's going to make them worse, then they're more likely to stop it than if they see it as like a legitimate treatment for their, you know, cognitive symptoms or anxiety, which they make those symptoms better, just like any other drug does, because they spike and crash dopamine levels quickly, and so you run into problems with control of those particular drug classes and also lowering dopamine tone over time, in my experience. So a good understanding of the biology and helping our patients to get that helps them to kind of go along with doing their part of making the changes that need to be made for them to get in recovery and stay in recovery, and those changes aren't easy. So everything we can do to help them, I think, is very important. And so this is just a similar cartoon to the one that we looked at before, but this just shows that all the medications that have ever been shown to help people to get in recovery and stay in recovery from addiction all do so by affecting one of these targets in the midbrain, one of the variables that adds up to dopamine tone. You know, Camprol works here on this glutamate receptor. Chantix works here by improving the tonic release of dopamine, like raising midbrain dopamine tone kind of over the course of days to weeks rather than minutes, right? Which is what we want. We want to stop spiking and crashing dopamine, but we want to more kind of naturally, less rapidly bring the dopamine tone up. You know, there's a difference between dopamine tone and the spike and crash. And we want to improve dopamine tone and have the patient stop spiking and crashing dopamine. Because when you spike and crash dopamine, like I said earlier, that makes the problem worse. And it leads to discontrol and abuse and all that other stuff. But all of the medications and everything that we do, the nursing and I, helps raise midbrain dopamine tone or stabilize it through actions on one of these receptors. Wellbutrin keeps dopamine in the brain longer after it's been made and released. some of the anti-seizure medications that I use help regulate dopamine release in response to reward through this GABA receptor, and don't spike dopamine like the benzos do, but can help with anxiety without making those problems worse, and so on and so forth. I don't have to get into those. Won't get into the detail too much, but just know that all the medications that we do specifically target those parts of the brain where the problem is. And I think that's it. These are my references. This is a good book that Howard Wetzman was one of my mentors that taught me a lot of this. He helped write that American Society of Addiction Medicine definition of addiction. He has a really good book on Amazon that's like $13 that's good for parents and patients and even for providers. If any if you guys get asked about that, you can send them to Amazon to get that book by Dr. Wetzman. And then the American Society of Addiction Medicine has a lot of information on addiction, and that definition is there, kind of spelled out in more detail. But with that, I think I'm finished, and I will take any questions if anybody has any. I know I went over a lot of things and pretty quickly. Does anybody have anything to ask?
Yeah, I got a quick question, Doc, on you were talking about the midbrain dopamine levels raising and falling to the chemicals and behavioral changes.
Right.
So for the behavioral parts, I kind of understand a little bit more about that. That's what we work on. For the chemical changes on your end, when it comes to the medications, are those chemical changes going to be raising those midbrain dopamine levels permanently? I guess, like, what's the influence on that, especially thinking about how they were also using their own, I guess, sort of self-medications and how that affected their brain. I don't know if that question makes sense, but
yeah, no, it does make sense. I tend to think as medications as temporary. I tend to think as those chemical changes as temporary. The ones that we make last longer than the ones that they're making, and that's why they're therapeutic, right? But I think the brain may, in different interventions, kind of, because eventually you get some kind of tolerance to those chemical changes, right? And that happens very quickly with drugs that patients are using. Maybe happens with the medications that I use, but a lot more slowly. So I think of all medications as temporary. I think the concept is medical stabilization. So I think I want to get them on as many medications as they need as quickly as I can, and use that as a tool and a bridge to get them plugged into the non-medication things that they can do, which I believe make more permanent changes in midbrain dopamine tone, like meditation, for example. I think you could, patients will always have, even those, it's a lifelong thing, right? But I think, get the medications on board, get them plugged into the therapy and the community recovery things, the coping skills, the self-care stuff that can raise midbrain dopamine tone based on the daily actions that they can take and kind of keep that dopamine tone up. But I think those are probably longer lasting effects and more permanent, one day at a time, than the medication intervention. So I think, but medications are quick and easy. So that's kind of, we have them here for 9 weeks, and I can do a lot of that while we get all the other stuff in place. But eventually, if they don't get all the other stuff in place, they're a lot more likely to relapse anyway, right? So it becomes a bit of a moot point in the long run. But yeah, and I think you can look at, increase and some of that happens with stopping using too, and the things like increase in dopamine receptor density and things like that, I think are more permanent in the long run. I think there was something else I wanted to say, but did that cover your question, Grant?
yeah, that made sense to me.
I was going to say some people stay on medications longer than others, and if some people find that being on Deplin and Wellbutrin for the rest of their life with their recovery program works better than not, then there's probably some biological logic behind that. And I think everybody's different too in terms of plasticity and the chronicity of the medications and so on and so forth. And some of it, like I said, they all work different too. Like Deplin, for example, helps your brain make dopamine. And it's always going to do that because it uses your body's natural machinery to do that. So I don't think there's ever going to be tolerance built to that. So Deplin is one of the ones that I think people probably do better on longer term than some of the other medications. But yeah, generally speaking, the non-medication stuff is longer lived than the medication interventions, I think. Good question. Any other questions or comments, clarifications people want or need?
This isn't really a question. I just wonder, like you said, somebody can stay on Wellbutrin and Deplin just for the rest of their life. Does it ever like just stop working? Like, is it gonna work? Like if somebody actually stays on it for the rest of their life?
You know, that's a good question. I think some form of tolerance probably does build over time, but it may take years or whatever. I think it's different for every medication. With Wellbutrin, you know, Wellbutrin is inhibiting a reuptake inhibitor pump in the brain, and I think over time you may generate more of those pumps to compensate for the presence of that Wellbutrin, but that process is a lot slower than, say, tolerance that would build to something that's causing a direct release of dopamine, like an amphetamine. You know, and that's why Wellbutrin would be preferred over amphetamine. That's one of the reasons. The other is that it doesn't spike and crash dopamine levels like amphetamine does, but it and doesn't deplete dopamine levels. Yeah. But yeah, I mean, and I don't know if anyone's ever really studied that, Grant, Michelle, because I mean, what happens is if they don't do the outside recovery stuff, then they relapse anyway. So even if but just because the medications don't do the whole job, right? You can raise the chemicals, but you also need more receptors, for example. So the things that meditation, for example, the benefits of that on this neurobiological problem, there isn't any medication that does that, but those benefits I think are necessary to get the brain healed as a whole. So if they don't do those other things, then they're not going to do well, regardless of whether the medication, if the medication did work forever, there's still a need for those other things. Does that make sense? And addiction is so hard. It's such a resilient and difficult disease. Repugnant is a good word. It's so hard to treat that you have to do everything. So the people that, if the medications did work indefinitely, you know, at the best, you'd be decreasing their use over time, which would be okay, but it doesn't really allow them to get, I don't know. My experience has been they have to do it all of their relapsing. So.
And besides meditation, like what are some other non-medication?
Yeah. So service, like doing things for other people, altruism, giving is a big principle in those community recovery resources. Personal inventory, self-reflection, and this is where the therapy part that you guys do with them, I think, helps the most. Or that's an outsider looking in. You know, it's more complicated than that, but self-reflection and knowing yourself better. Insight, that process of insight occurs in a part of the brain and mind that improves midbrain dopamine tone, believe it or not. So we have trouble thinking of the brain as being able to change itself through what it does, but it certainly does that, and that change usually is, in a very simple terms, increased midbrain dopamine tone with respect to the patient population and the goals that we're talking about. I mean, it's certainly more complicated than that. Serotonin is involved, you know, other things. But the brain is just like the heart. If you use it to do certain things, it changes itself in a way that it's now healthier and better, and the chemistry is different, and it actually would even look different under a microscope. And you know, and that's what all of those actions do. I think the groups here do it some through that insight process. I think individual therapy does it, and then you know, meditation does it, service does it. You know, all of the principles and practices that are a part of community recovery do it, and we introduce them to a lot of that here, and they start doing a lot of that with us. Good questions. Good job paying attention, actually, with all that talking. Anybody else have any questions or things that weren't clear, or clarifications? I'm a board certified psychiatrist, and I think it's just as, I'm not, when you hear some of that, it gets interpreted sometimes as, well, dual diagnosis or co-occurring disorders aren't an important thing to know about and pay attention to. And that's not what I'm saying. I do believe some of that is overdiagnosed based on a misunderstanding of the underlying biology in our patients and pre-existing biology. And I think there probably needs to be a reckoning in the DSM with that reality. But you guys have seen the patients that are really bipolar that come through. If I don't treat that, they don't stay. And if they're not well enough to stay in group or get along with everybody here and all that, then they're never going to get into recovery. So the two definitely go hand in hand. But sometimes if I'm putting so much focus on this, that gets lost in the mix, and I don't want it to. But anyway. But I think I remember a study that said something like 80% of our patients meet criteria for major depressive disorder when they walk through the door. Well, is that major depressive disorder, or is it just depression because of the underlying biology of addiction? Same with anxiety. Those words just mean, doc, I don't feel good, and I don't think it's caused by the drugs. I think it's kind of a part of me and always been there, because it was there before I ever used the drug, and it's there 6 months after I used the drug. Well, you can call that depression, you can call that addiction. It's just a semantic argument a lot of times. But I think it's important, especially when the words we use dictate treatment, right? And many antidepressants don't really help with that underlying neurobiological dopamine tone issue. And some anxiety medicines or ADHD medicines, I believe, make that underlying biology worse. So the semantic argument and what words we use are really mostly important in terms of how we treat them. Because at the end of the day, I'm just trying to help them feel better and do better. And you know what? Most of the medications that I use are, like Wellbutrin, for example, is a good medication for major depressive disorder, a good medication for ADHD, and a good medication for drug use, right? And so I can say I'm giving them that for the underlying biology of addiction or the disease of addiction, or I can say I'm giving it to them for major depressive disorder, ADHD, smoking cessation. It doesn't matter, and we use different language for legal reasons or reimbursement reasons, but really what we're doing is helping the patient with the agent, and that help is a direct result of what it does to the biology of their brain, right? And it's the same with mood stabilizers and a lot of the medications that we use. They help with the symptoms and help the patients feel better and do better, even though, regardless of what label we apply to, the patient's problem. So we just don't make the problem worse, number one. And we want to choose meds that are going to make it better. So, okay. Anybody else? Okay, everyone, thank you. Figure out how to stop recording.